Alterations of pulmonary function. One of the most common symptoms of pulmonary disease is dyspnea, or the uncomfortable sensation of breathing difficulty. Orthopnea refers to dyspnea that occurs when lying down and is often associated with heart or lung disease. Paroxysmal nocturnal dyspnea describes sudden episodes of severe shortness of breath that awaken a person from sleep. These symptoms signal impaired ventilation or gas exchange and require careful evaluation. A cough is another frequent sign of pulmonary disease and may be either acute, lasting less than 3 weeks, or chronic, persisting for longer. The presence of abnormal sputum, including blood-tinged mucus known as hemoptysis, may indicate infection or serious lung pathology. Breathing patterns also provide clues, such as deep and rapid Kussmaul respirations or the alternating pattern of Cheyne-Stokes respirations. These patterns are often seen in severe illness or neurological dysfunction. Changes in carbon dioxide levels can manifest as either hypoventilation with elevated levels or hyperventilation with reduced levels. Cyanosis, a bluish discoloration of the skin or mucous membranes, indicates significant oxygen desaturation. Clubbing, or the bulbous enlargement of the fingers, is a chronic sign associated with diseases that reduce oxygen levels in the blood. Pulmonary disorders can also cause pain, often described as sharp and worsened by breathing or coughing. Clubbing is a visible sign of chronic hypoxemia and is marked by the painless enlargement of the fingertips or toes. It is most often associated with conditions that cause long-term oxygen deficiency, such as cystic fibrosis, pulmonary fibrosis, or congenital heart disease. The change in shape and angle of the nail bed is typically gradual. Clubbing reflects ongoing tissue hypoxia and requires further investigation to determine the underlying cause. Pulmonary disease or injury can lead to both carbon dioxide retention and oxygen deprivation. Hypercapnia refers to an increase in carbon dioxide in the arterial blood, often resulting from hypoventilation. Hypoxemia is a reduction in the oxygen content of arterial blood and can result from ventilation-perfusion mismatch, diffusion problems, or shunting. When oxygen levels are low throughout body tissues, the condition is called hypoxia, which may or may not occur with hypoxemia. One of the most critical causes of hypoxemia is a mismatch between ventilation and perfusion. Ideally, air entering the lungs should be evenly matched with blood flow in the pulmonary capillaries. When this balance is disturbed, such as with blocked airways or blood clots, oxygenation suffers. A severe mismatch or complete absence of ventilation to perfuse areas is known as shunting. Disorders of the chest wall can restrict lung expansion, making breathing more difficult. These restrictions may result from structural deformation, immobilization, or excess body weight. One example is flail chest, in which multiple rib fractures cause a portion of the chest wall to move independently during respiration. This paradoxical motion interferes with ventilation and increases the work of breathing. Flail chest occurs when a segment of the rib cage becomes detached due to multiple fractures. During inhalation, this segment moves inward instead of outward, and during exhalation, it bulges outward, opposite to the rest of the chest wall. This abnormal motion severely impairs breathing efficiency. Treatment typically includes pain control, oxygen support, and stabilization of the chest wall. Pleural abnormalities involve damage or disruption to the membrane surrounding the lungs. A pneumothorax occurs when air enters the pleural space, leading to partial or complete lung collapse. It can be open, allowing air to move in and out, or a tension pneumothorax, where trapped air increases pressure and compresses lung and heart structures. Spontaneous pneumothorax can occur without trauma, while secondary pneumothorax is linked to underlying lung disease. Pleural effusion is the accumulation of fluid in the pleural space, which surrounds the lungs and limits their expansion. The fluid may be clear and watery, known as a transidate, or protein-rich and cloudy, called an exudate. Other forms include hemothorax, which involves blood in the pleural cavity, emphysema, which contains pus due to infection, and chylothorax, where lymphatic fluid called chyle accumulates. Each type requires specific evaluation and often drainage to restore lung function. Restrictive lung diseases limit lung expansion, making it difficult to breathe in deeply. One example is aspiration, where food, liquid, or other substances accidentally enter the lungs, leading to inflammation and infection. Atelectasis, or collapse of lung tissue, can occur from external pressure, airway blockage, or loss of surfactant that normally helps keep the alveoli open. Bronchiectasis is a condition where the bronchi become permanently widened and scarred, leading to mucus accumulation and repeated infections. Bronchiolitis is a small airway disease most common in children, but it can also affect adults with chronic bronchitis or after inhalation of harmful gases. The condition leads to inflammation and obstruction of the bronchioles, often following viral infection. Pulmonary fibrosis involves excessive fibrous tissue buildup in the lungs, which stiffens the lung tissue and makes breathing progressively more difficult. It may arise spontaneously or as a result of previous injury or illness. Inhalation of toxic substances can lead to several serious lung conditions. Pneumoconiosis results from long-term exposure to dust such as silica, asbestos, or coal, causing permanent lung damage. Another condition, hypersensitivity alveolitis, is caused by repeated inhalation of organic particles or chemical fumes and leads to an allergic-like inflammatory reaction in the lung tissue. Pulmonary edema, the buildup of fluid in the lung tissue and alveoli, further reduces gas exchange and causes shortness of breath. This flowchart outlines the pathophysiology of pulmonary edema in restrictive lung diseases. It begins with three potential initiating events: increased left atrial pressure from conditions like valvular dysfunction or coronary artery disease, injury to the capillary endothelium from acute respiratory distress syndrome or inhalational injury, and blockage of lymphatic vessels due to surgery, tumors, or fibrosis. Increased atrial pressure raises pulmonary capillary hydrostatic pressure, while injury to the capillary endothelium increases permeability and disrupts surfactant production. Meanwhile, blocked lymphatics impair fluid removal. These mechanisms converge to cause fluid accumulation, either from capillaries into the interstitial space, or from plasma into both the interstitial space and alveoli, ultimately resulting in pulmonary edema. Acute respiratory distress syndrome, or ARDS, is a severe condition marked by acute lung inflammation and widespread injury to the alveolocapillary membrane. This injury can result from trauma, infection, or other sources of intense inflammation. Radiographic findings typically reveal bilateral infiltrates, and blood gas analysis shows a decreased ratio of arterial oxygen to inspired oxygen, or POW to FiO. ARDS progresses through three distinct phases. The exudative phase occurs within the first 72 hours and involves fluid leakage into the alveoli. Next is the proliferative phase, spanning from day 4 to 21, marked by attempts at lung repair. Finally, the fibrotic phase, occurring between days 14 to 21, involves scarring and stiffening of lung tissue, which can lead to long-term respiratory compromise. Acute respiratory distress syndrome progresses through three distinct phases. The exudative phase, occurring within the first 72 hours, involves fluid leakage into the alveoli. The proliferative phase follows within 4 to 21 days and is marked by inflammation and attempted repair. Finally, in the fibrotic phase, which occurs around day 14 to 21, scarring replaces normal lung tissue, resulting in long-term respiratory impairment if the patient survives. Obstructive lung diseases are characterized by airway narrowing, which makes it more difficult to exhale than to inhale. This leads to air trapping, increased work of breathing, and the use of accessory muscles during expiration. Common symptoms include wheezing, shortness of breath, and prolonged exhalation. These diseases worsen with time and require both preventive and symptom-relieving treatment strategies. Asthma is a chronic inflammatory disorder that causes episodes of reversible airway obstruction. In response to triggers like allergens or exercise, the airways become inflamed, muscles around them constrict, and excess mucus is produced. Symptoms include wheezing, shortness of breath, coughing, and chest tightness, especially at night or in the early morning. Treatment includes medications such as corticosteroids and bronchodilators, and severe cases may result in status asthmaticus, a life-threatening condition. This slide likely expands on the effects of airway obstruction. In obstructive lung disease, air becomes trapped in the lungs due to narrowed or collapsed airways, especially during exhalation. Over time, this leads to hyperinflation of the lungs, poor gas exchange, and increased carbon dioxide levels. The prolonged struggle to breathe results in fatigue and progressive decline in respiratory function. Chronic obstructive pulmonary disease is a common and progressive condition that leads to persistent airflow limitation. It includes both chronic bronchitis and emphysema, and is strongly associated with long-term smoking, exposure to air pollutants, and genetic factors. The airflow obstruction is not fully reversible and worsens over time. COPD is the leading cause of chronic respiratory disability worldwide. Chronic bronchitis is defined by the presence of a productive cough lasting at least 3 months over 2 consecutive years. Inhaled irritants, such as tobacco smoke, cause the airway linings to become inflamed and increase mucus production. The mucus becomes thick and difficult to clear, leading to airway obstruction, chronic infection, and ongoing inflammation. Treatment may include bronchodilators, expectorants, and physical therapy to loosen secretions. Emphysema involves permanent enlargement of the air spaces in the lungs and the destruction of alveolar walls. This damage occurs without obvious fibrosis and leads to the loss of elastic recoil that normally helps expel air during exhalation. One inherited cause of emphysema is alpha-1 antitrypsin deficiency, which makes the lung tissue more vulnerable to damage. Patients often present with shortness of breath, a barrel-shaped chest, and a prolonged expiratory phase. As emphysema progresses, patients may experience increasing difficulty with daily activities due to reduced oxygen intake and higher carbon dioxide retention. Air gets trapped in the lungs, leading to hyperinflation and flattening of the diaphragm. These mechanical changes reduce respiratory efficiency and increase the work of breathing. Management includes bronchodilators, supplemental oxygen, pulmonary rehabilitation, and smoking cessation. This slide likely summarizes the differences and overlap between asthma, chronic bronchitis, and emphysema, all of which fall under the umbrella of obstructive lung disease. Each condition has unique causes, pathology, and treatment strategies, but they share the common feature of impaired airflow. Early diagnosis and individualized treatment plans are essential to preserve lung function and improve quality of life. Education and lifestyle modifications play a critical role in managing long-term outcomes. Acute bronchitis is an inflammation or infection of the bronchial airways, usually following a viral illness such as the common cold or flu. Patients present with a persistent cough, sometimes accompanied by fever, wheezing, or chest discomfort. Unlike pneumonia, bronchitis does not show signs of lung consolidation on imaging. Most cases resolve on their own with supportive care, though bacterial cases may require antibiotics. Pneumonia is an infection of the lower respiratory tract that can be caused by bacteria, viruses, fungi, or parasites. It may develop in the community or in healthcare settings, including hospitals and nursing homes. Streptococcus pneumoniae and influenza virus are common causes, especially in community-acquired cases. Symptoms often include cough, fever, shortness of breath, and chest pain, and treatment is guided by the cause and severity of illness. This slide likely continues the discussion on pneumonia or introduces other types of respiratory infections. Ventilator-associated pneumonia is a significant concern in critically ill patients, as it increases the risk of complications and mortality. Preventive strategies such as good oral hygiene and proper ventilator care are essential. Accurate diagnosis through clinical evaluation and imaging guides effective treatment. Tuberculosis is a serious infection caused by the bacterium Mycobacterium tuberculosis. It is spread through airborne transmission and remains one of the leading causes of death from a curable infectious disease worldwide. The bacteria form granulomas known as tubercles, which contain the infection but can later reactivate. A hallmark of tuberculosis is caseous necrosis, cheese-like tissue destruction visible under a microscope, and diagnosis is often confirmed by a positive tuberculin skin test or chest imaging. Lung abscesses occur when infection leads to localized necrosis of lung tissue, forming a cavity filled with pus. These abscesses can rupture into airways, resulting in coughing up foul-smelling sputum. Cavitation describes the process where lung tissue is destroyed, leaving a hollow space. Treatment includes antibiotics, and in some cases, surgical drainage or resection may be required. A pulmonary embolism occurs when a clot or other embolus travels to the lungs and blocks part of the pulmonary vascular bed. These emboli often originate from deep veins in the legs, making them a complication of deep vein thrombosis. Depending on the size and location of the embolus, symptoms may range from mild shortness of breath to sudden death. Prompt recognition and treatment are essential to restore circulation and prevent recurrence. This slide likely continues the discussion on pulmonary embolism or introduces related disorders. Emboli may consist of blood clots, fat, air bubbles, or even amniotic fluid, all capable of obstructing pulmonary vessels. Common risk factors include surgery, immobility, trauma, and clotting disorders. Early prevention strategies, such as anticoagulants and mobility, are critical in hospitalized patients. Pulmonary artery hypertension is a condition in which the mean pulmonary artery pressure is significantly elevated, 5 to 10 millimeters of mercury above normal or greater than 25 millimeters of mercury at rest. It can be caused by genetic mutations, drugs, left heart disease, chronic lung disease, or chronic thromboembolism. The increased pressure places strain on the right side of the heart and progressively reduces oxygen exchange. Over time, it can lead to right heart failure if not managed. Cor pulmonale is a condition in which pulmonary hypertension causes chronic pressure overload in the right ventricle, eventually leading to right ventricular enlargement and dysfunction. Unlike heart failure from left-sided disease, cor pulmonale originates in the lungs. It is commonly seen in patients with chronic lung disease such as COPD. Symptoms include swelling of the legs, shortness of breath, and jugular vein distension. This slide may further explain the pathophysiology of cor pulmonale or the progression of pulmonary hypertension. As right ventricular pressure rises, blood flow to the lungs decreases, leading to worsening hypoxia. Treatment includes managing the underlying lung condition and sometimes using medications to lower pulmonary artery pressure. Early recognition can slow disease progression and improve quality of life. Laryngeal cancer typically originates on the true vocal cords, but may also occur above or below them. The most common symptom is persistent hoarseness, followed by shortness of breath and a chronic cough. Smoking and alcohol use are major risk factors. Treatment options may include surgery, radiation, or chemotherapy, depending on the stage and location of the tumor. This slide likely presents anatomical illustrations or epidemiologic data on cancers of the respiratory tract. Laryngeal cancer, although less common than lung cancer, can greatly impact voice and breathing if not detected early. Supraglottic and subglottic tumors are less frequent, but often more advanced at diagnosis. Screening and early evaluation of voice changes are essential. Lung cancer is one of the deadliest cancers and is strongly linked to cigarette smoking, which causes nearly 80% of all cases. Individuals with chronic obstructive pulmonary disease are at even greater risk. Lung cancer is categorized into non-small cell cancers, such as squamous cell carcinoma, adenocarcinoma, and large cell carcinoma, and small cell carcinoma, which originates from neuroendocrine cells and is more aggressive. Early symptoms are often vague, and diagnosis usually occurs at an advanced stage.